Let's enable transcript. We're going to record on this side as well. That is going, and we'll record here. Perfect. So part of this is in a way a scripted interview. So there are things that are going to sound very scripted as a result. But the intent is still for it to be a fairly conversational style interview. So with that, I'll get started. So thank you so much for joining me today on this one-on-one interview. As you know, the aim of the interview is to hear more about your experiences within the domains of equity, diversity, and inclusivity. Your participation in the interview is voluntary, so if at any point you want to take a pause, step out, stop early, you're welcome to do so. Just let me know. As you know, this interview is recorded in order to generate a transcript, which will be anonymized. So even if there's names said, they won't carry forward. So with all that said, do I have your consent to start?
Yes.
Before we actually get going with the interview, do you have any questions for me?
No.
All right.
I mean, again, I'd assume if I have questions through the course of this, it'd be perfectly appropriate to ask. So yes. I'm fine with that.
Absolutely. So for the record, can you please state your age, your gender, and your role at the Cancer Center?
So Jim Wright, I am 59 years of age, and yes, it's not really the Cancer Center per se, but my role currently is the director of OCOG.
And your gender?
And gender is male.
Excellent. So the first question asks you to explain or define 3 specific terms. So we will cover them each in turn. So the first one is, how would you define or explain the term equity to someone?
Well, I guess in my mind, the question is, how would I explain it to somebody else? I would explain it to somebody else by saying equity is the principle of trying to ensure that people have equal access to opportunities, responsibilities, in medicine, leadership roles, decision-making, and those sorts of issues.
Okay. And then how would you define or explain diversity?
So diversity, again, I'm thinking about how I would explain this to my mother. So diversity, to me, is the principle of ensuring that that those groups of people that are in positions to make decisions reflect the bodies of individuals for which they are making decisions.
All right. And any specific aspects that come to mind, like when you classically think of diversity, are there certain things that come to the forefront?
I think of many of these issues as being somewhat dependent on the baseline state. So, even issues like cultural representation are going to depend on the group of people that you're dealing with. But no, I mean, there's obviously a classic number of issues that would include gender, sexual orientation, color of one's skin, languages spoken, geography, et cetera, et cetera.
Perfect. And then the last term that I'll get you to explain or define is inclusivity or inclusion.
Yeah, I mean, again, I think of many of these kind of definitions as somewhat overlapping. I mean, they're big Venn diagrams with lots of overlap. And so I think the piece of inclusivity is really just to ensure there, in a way, aren't barriers to achieve the first 2 goals, which is, equity and diversity.
Mm-hmm. And so when you think of barriers, what does that mean?
Again, can mean a lot of different things. It could mean that a barrier is based on, I mean, again, the classic example might be that women typically have a higher proportionate responsibility for childcare. So if as an organization we continue to have meetings at 7 a.m. or at 5 p.m., which is harder for the average woman with children to attend, it's a barrier to their involvement in many various committees.
For sure. So keeping those themes and those definitions in mind, do you see these three domains influencing the patient-clinician relationship or those interactions? And if so, in what ways?
Influencing. Well, again, I guess I look at many of these things the same way I would informational needs, which is we're all going to be different. And I think our roles as clinicians is to try and adjust how we present information and how we facilitate decision making based on the abilities and the interests and, background and the social realities of our patients. So I think it really just gives us even more to think about as we try and, transcend a large number of potential barriers. So it's not going to be possible for me to understand really even how somebody with cancer might make a decision. So it's clearly going to be even that much more difficult to understand how somebody who is quote unquote different than me is going to make decisions about cancer, because they're already different than me just having cancer.
Mm-hmm. And so I think this plays well into that next question, which is, have you been a part of a clinical scenario or encountered a clinical scenario where these domains directly played a role in the patient interaction that you had, whether it was their decision making, their ability to establish trust in you, in communicating difficult news, anything along those lines in the way of an anecdote?
Again, it's a difficult one to kind of just right off the top of my head think of a specific example where there was a high level of depth to that issue. I guess I see my style sometimes as a clinician as being very informal, and I typically like to recognize when I'm helping people make decisions that there's no way I can help them. So even the more classic example of, well, what would you do? I typically go out of my way to say that even when healthcare providers believe we think we know what we would do in a certain situation, the evidence suggests that we don't necessarily do that. And so I will often do my best just to kind of point out that, if it's a 58-year-old man or whatever, I'm going to point out the clear, obvious differences. I may not go into a lot of depth with respect to, in fairness, I don't know that I've ever said to somebody that this decision is going to be different for you or I because of our sexual orientation, as an example. Mm-hmm. But I would stick to more obvious differences in terms of demographics. How can I make a decision for a 65-year-old woman, and as an example.
And how is exploring that dialogue often received by your patients?
I think, and again, I haven't necessarily asked about what this means to them, but I believe what I'm doing is I'm giving them license to understand that the decisions have to be made for what they see as the right thing to do and not really for myself. Again, I think it's a more obvious issue for me because I'm in Brantford on every couple of weeks. And obviously there I see a fairly large proportion of Indigenous people. That's probably the most obvious visible minority that I see on a consistent basis. And so, there it's recognizing that they might make decisions differently. It's obviously a bit more complicated than that because there's even certain terms and things I've learned over the years that don't necessarily align perfectly. So I'll try and have some sensitivity with how I express things. But fundamentally, I think I'm giving people license to understand they have to make decisions that are correct for their reality, not necessarily for my interpretation of their reality.
Can I ask you to explore that, if you're willing, a little bit further when you say, there's things that you've had to learn not to say or that they don't align best with, say, this particular group of patients in Brantford?
Well, it's just expressions like, passing has different meanings. So, as opposed to dying, I think they typically prefer the word passing. So I might use that expression when I'm talking about end of life planning, for example. So I guess it's not really, like I'm not going to win any prizes for my cultural sensitivity because I pick up one or two expressions. But I think even to use one or two expressions sometimes is again just trying to humanize yourself with your patients and have them understand again that whole principle of how I want to respect a different set of beliefs to make decisions. Again, you could even argue that a lot of the people that come and talk to us about naturopathic therapies and things, I mean, yeah, I know I'm being transcribed, but at some level in my brain, it's all bullshit. But I still want to give them license to be able to make those choices that are correct for them. That's not really so much one of the classic examples of, EDI, but it just highlights that the levels of differences between how we think and how we make decisions are innumerable almost.
So really what I'm hearing is that theme of giving people space for personhood and for being treated as an individual as opposed to an algorithmic outcome.
Yeah, no, personhood is a good word. It's not one that's in my usual vocabulary, but in this context, I think that's the best word, yes. I guess I think of it more as kind of individual freedoms, but personhood's a good word for it.
And so on the converse side of that, have you ever yourself been involved in or borne witness to a clinical encounter where it was done poorly, where there was a lack of acknowledgement of those domains and it directly influenced patient care? Or was there an example that you witnessed that it was done really, really well that stands out in your mind?
Again, it's a difficult question because, all this gray hair means I've been doing this for a long time. And the reality is that, I think most of those kind of formative moments really almost happen more when you're in residency and fellowship and you are in a position to see essentially your colleagues and their interactions. So it's been a long time since, I've seen or heard things that just kind of struck me as being particularly insensitive. But, there's still very subtle things. I mean, one of the head and neck surgeons still had a habit of calling people chief. Well, when the person clearly has a name that aligns with an indigenous ancestry, it's probably maybe think about it a little bit more as an example. It's probably not the best word to use for anybody, but that's probably the only thing I can think of in even the last 10 or 15 years.
Mm-hmm. And have you, in your role in leadership, ever been sort of asked to have a conversation with someone in regards to their maybe understanding or lack of sensitivity around these issues?
Again, this is from a patient perspective.
Well, I mean, even say professionally within your division or department.
Well, I mean, again, maybe this is too tangential. You can kind of bring me back on track if you want. But, I mean, these discussions happen with a fair amount of frequency these days. So even when you post a position to recruit, there's usually some discussion. I mean, part of that discussion is just helping everybody understand where, for example, our institutions stand on these sorts of issues. So I think the discussion is a good thing. I can't think of more concrete examples at a patient level. Mm-hmm. It sometimes comes up, there's a whole panel to look at people that don't have OHIP coverage. Mm-hmm. I think sometimes issues of, culture and geography, et cetera, sometimes come up in those meetings. But again, it's not really a clinical interaction that I'm witnessing myself.
Fair. When you think about these things, and obviously you've highlighted that there is a need for, say, certain phrasing or spending certain times or being more mindful, when you reflect on your professional career, had you ever received any formal or informal training within these domains?
Again, there's never really been anything that's been particularly mandatory, if you will, for example. But I think having a leadership role over most of the last 10 years, there were certainly attempts to and it sounds funny to use the word, but to include the thinking in the way we approach decision making. So, the entire cancer clinic executive had a retreat at the residential school in Brantford as an example. So, based on the speakers, based on the building you were in, it was pretty hard not to understand that you were there for a specific reason. Again, through the regional lead for Aboriginal health, there's a whole series of teaching videos that people have been encouraged to kind of sit down and go through. Those types of learning opportunities don't exist for necessarily every domain in the whole universe of EDI, but they are examples of where there have been opportunities to further your own learning and even, have a bit of a group think and group recognition of some of these issues.
And so you said that they weren't necessarily mandatory, but was it implied that you should attend, or was there some sort of subtext that this should be something part of your plan?
Well, certainly the retreat was mandatory, so, wasn't too much choice on that one. I guess if you didn't want to go on the tour, if you will, of the residential school, I'm not sure they took attendance per se, but so again, that was a purposeful decision to be there at that place. So I would say that was more mandatory. The video is not necessarily, but again, I think this kind of goes back to even leadership. And Ralph was always a very, in tune kind of sensitive guy who I think would use a carrot to encourage thinking as opposed to a stick.
Right. And so were there other opportunities you've had in your own personal life that sort of allowed for you to explore these themes further, or has it largely been through your professional sphere?
Again, there's some gray zone between those options. So, I'm very good friends personally with Marco Simonovic, who happens to chair the surgical EDI committee. Mm-hmm. And so, whether when we have those discussions, is that a personal discussion or is it a professional discussion? It's somewhere in the middle of those two things. Mm-hmm. So, we can have a discussion about whether, quotas for having people with African American ancestry at McMaster is the right thing to do, or, without divulging personal details, have some discussion about even how those topics were reviewed within his own committee. Mm-hmm. But, when you know somebody that well, it really is as much a personal discussion. And if our wives are in the room, I would classify that as personal as opposed to necessarily business.
Right. And then if you think back at any point in your training, were you ever exposed to these ideas or these topics, or were you ever engaged in thinking about these things as it related to your clinical role?
Again, I can't really think of formal training. Again, we're going back a few years, right? It wasn't on the curriculum in residency in 1992 that I remember. I'd like to think that if I use your word of personhood, that there are some fundamental issues here that have been important for a long, long time, but increasingly the recognition of their importance has driven a little bit more organizational structure. So mm-hmm. Fancy way of saying I think it didn't take a really, really high level of sensitivity to understand there were issues 30 years ago.
Right.
But clearly not everybody did. So it's necessitated the need to formalize some of these issues. And the Department of Oncology still doesn't really have an EDI committee. We can wait to be told that we have to do it, or we can try and get out ahead of the curve a little bit, wait until we see what other people are doing. But, there's not necessarily a right or wrong answer with where we are in those things, but we're starting to look like we're falling behind a little bit.
And so when you think about that, say, cultural shift where these terms are becoming more and more part of like the societal milieu and zeitgeist, has there been a change in sort of the perception of it within the leadership that you've noticed where, are people gung-ho for it? Has there been some halting reluctance to incorporate it? Are people uncomfortable? What has that looked like?
Well, I mean, the reality is you've given me a range, and I think that's the reality. I think there's a range of reactions. So, again, even in the process of recruitment, which is a more formal process led by the university but embedded within the hospital system, there's all kinds of discussions about what it is that we think we should be doing, both as institutions and as a committee. So, I mean, some of it, in fairness, does get a little bit confusing. So, there was a fair amount of discussion with our last recruitment about how as a committee we were going to recognize these things and how as a committee we were going to fulfill the mandates that we'd been provided by the university. But, there are some people that are a little bit more passive aggressive, for a better word. So you're telling me that we're going to try and do our best to ensure that if two people are equal, we're going to hire the person who has brown skin, but we're not allowed a picture of the person to know if they have brown skin. But, it's getting very granular and maybe a bit concrete. Most
Mm-hmm.
people were not like that.
Mm-hmm. And in your own personal experience, when you think back to when you were, say, more starkly faced with these concerns or where you encountered it within a patient setting, having to face it, was it something that was easy or was it ever uncomfortable?
Well, again, I think the discomfort is recognizing that, I'm a white man with gray hair who's, whether I believe I worked hard or not, the reality is the system was always tilted in my favor. That's not necessarily an easy way to kind of look at your life, right? I mean, I like to kind of believe that a lot of my success has been personally driven. And so you don't want to kind of acknowledge that you worked hard for it, but that you're in a system tilted in your favor all along. That's maybe the most discomfort with that has been as much just thinking through history from an Indigenous perspective. Mm-hmm. So you don't typically walk away from some of the discussions about Sir John A. Macdonald feeling really good about your role in colonization, for example. So again, I might say if there's no discomfort, you're probably not really thinking about the issues in the level of depth that is required.
And then knowing that it is uncomfortable at times, how do you keep yourself engaged, knowing that it is often easier to leave that space of discomfort?
Well, again, I still might argue that it's still easier for me to kind of stay engaged, recognize, it's like so many things, just recognize that discomfort and why it's there. But to walk away from it isn't really solving any issues. So I'm happy to kind of recognize there's a bit of discomfort, but it's also easy to say I'm going to recognize a little bit of discomfort because I'm still the white guy with the gray hair that has all these opportunities for leadership roles. So, it's not sure that's necessarily answering your question, but maybe it's like any good relationship. If you don't think you're putting 55% into a relationship, it's probably not working out so well. You're not both putting in 55, but it should feel like that.
Right. Fair. So when you think about this, partially it is just a personal insight, but how comfortable do you feel when someone says, well, do you feel comfortable when talking about equity, diversity, and inclusivity? And are there any personal growing curves or learning curves that you've set for yourself?
Again, it's a good question. I guess I've never really thought of it formally in the way that I might other educational needs. I guess for me, I think the biggest issue is just not to take it off the radar screen. And so I'm quite comfortable kind of discussing those issues, even when I have, junior learners with me. I don't mind having those discussions. So, as topics might arise, regardless of how they get into my brain, I don't mind having those discussions and hearing other people's thoughts about the process. I mean, at the end of the day, so much of this is just trying to collect that kind of collective sense of where we need to go with some of these things, that I think dialogue is the key. I'm not convinced that committees always make the right decisions for things, but committees sometimes just provide an opportunity to have discussion. My guess is even with the surgical EDI committee, you've kind of self-selected the people that are interested and willing to have discussion. But I still think that's important to facilitate. So short answer is, not sure I have formal learning objectives. I think my personal objective is to stay engaged and to continue to try and think about the issues.
And then you mentioned that you're certainly very open to and wanting to engage in those conversations with junior learners. In what ways, if any, have you seen yourself being able to engage in that dialogue with learners? Like, do you have examples, knowing that this is something that requires training and requires discussion?
Well, I mean, again, I still think that telling somebody that they're likely going to begin the process of active dying is a little bit more difficult than having somebody in my clinic or working with somebody in my clinic who is a person of color and having some discussion about whether they have had experiences of what they would call discrimination through the course of their career in medicine. I don't think, I would typically phrase it to say, if you're not comfortable about it, there's no need to discuss, but, is it something that you'd be willing to talk about or that you've experienced? To be honest, I don't think I can think of anybody who has said no, but, in the last 5 years, maybe we're talking about 3 people.
Mm-hmm. And has that ever triggered any actionable change? Like, has that required any action to be taken on their behalf in terms of representation or allyship?
No, but, again, just if you look at it from a kind of sampling perspective, the fact of the matter is when people are junior in their careers, they haven't had, it's kind of like it's a bit of a Goldilocks period, right? They've clearly achieved an ability to avoid some barriers to get to the point where they're at. And the next set of barriers are likely more to do with leadership positions and decision-making roles within these larger institutions. So most people in their first 3 to 5 years are not going to be in positions of leadership opportunities. So it's really about, in a sense, you have to have that discussion with your colleagues that are 3 to 5 years on staff and with the people maybe even earlier than the people we see as residents and fellows. But, again, I know there's a lot more going on than that. I mean, how people may be treated differently doing early rotations in medicine, there's still probably examples, maybe not a lot, but I don't know if I'm kind of getting at the point there, but people that face a lot of barriers are not going to end up in clinic as a learner with me in the first place. And then the more subtle barriers of leadership opportunities, they haven't really gotten to a point where those are going to be an issue yet.
Mm-hmm. And I know that you mentioned about, engaging in dialogue with, say, junior faculty, people who have started their careers. Is there anything in place, or is there a culture within the division or department to allow for that space of conversation and discussion and have the ability to be vulnerable in that way?
Yeah, short answer is yes. Again, I know it's being anonymized, but it's difficult to kind of give specific examples with my colleagues without kind of dragging them into the loop. But, I have colleagues that are young women, mm-hmm. and I have had discussions with them about, strategies for leadership roles. And that discussion is typically a little bit different than some of the younger men, but, the reality is most of our hires more recently have been younger women. Mm-hmm. So sometimes there's even discussions about, that example about the times of our meetings is still a good example about, what can we do to make sure that you have the opportunity to participate in this committee?
Mm-hmm.
And, if that gets into discussions about, well, I don't want to be there if I'm just, to check off a box to say we've achieved something, I still think that's typically a healthy discussion to have.
Mm-hmm.
And in fairness,
sorry, go ahead.
That's all it is. I was just going to say, if that's all it is to check off a box, well, then you probably have a different problem to discuss.
Mm-hmm. And then I know that you said that, you're having slightly different discussions with, say, your junior female colleagues and perhaps some of the more junior male colleagues. In what ways? Like, what are things that you will counsel your female counterparts as opposed to your male counterparts?
Well, and maybe it's not so much necessarily the questions, but it's just ensuring that you recognize what those barriers may be, for example. So if you're recruiting somebody to sit on the business group executive, are there different barriers for different people?
Okay, fair enough. Now, looking more like personally, has there ever been a situation where you yourself were personally affected because another person that you were interacting with professionally or personally maybe didn't take the time to acknowledge certain parts of your own identities or your personhood or your lived experience that, or made assumptions about you that impacted you yourself?
I'm really kind of searching. I mean, there's certainly not been anything too dramatic. Again, maybe I'm trying to think of any examples. So again, it's where I get to sit with all of these privileges that sounds kind of odd that I can't even really come up with an example for you. Again, I remember giving a talk once out at the Turtle Clan and at Six Nations, and might have been referred to as there was some kind of term they used, and I don't even remember what it was, that I questioned whether it was a little bit derogatory, being the visitor, but I didn't really think it was necessarily my issue to judge, and it wasn't going to change the realities of anything. But again, I'm hard pressed to come up with anything else. I mean, there's a few patients over the years that might not like my decision making, if you will, but that's not really the kind of avenue that we're going down here. So no, I'm hard pressed to come up with a good example.
No, and that's fair. If it's not happened, it's not happened. We can't make it up. And then the last question that's part of the interview is there anything that we've not covered in this discussion that you think would be relevant, given that the overarching research goal here is to better understand how oncologists learn and understand the domains of EDI?
And just start the question again for me, sorry.
So is there anything else that you want to say as it relates to that theme or that overarching purpose?
Well, again, I think I recognized this before we started this series of questions, but I think it's increasingly obvious that so much of this sometimes comes down to issues like how we define things and how we use terms, and it's already a little bit confusing for some people, I think, when we have discussions about sex and gender and orientation. And I think sometimes it is useful to have discussions that help people develop definitions so that they can continue to talk about things and know that they're talking about the same thing. But I think it just reinforces that we probably do need to have some larger discussions and teaching opportunities and presentations that will help people understand where we're at with various definitions. It worries me a little bit in that when you try and organize something like that 10% of people that really understand it well will definitely be there. The other maybe 30% that have some interest will be there, and the 50% that probably should be there the most don't show up. But that's probably true of a lot of things, and maybe this is no different as an educational need, if you will. So it tends to kind of, float around all of us, maybe around some of us in administrative roles more than others. But so far it's been a fairly informal, kind of series of discussions and thoughts. So I think when the department chair realizes that we probably need a committee specifically to facilitate discussion, I think that would be a good thing.
And so you mentioned that, often it's the people who need it the most that will not attend. What are some thoughts that you have on trying to motivate and to increase intrinsic motivation to engage in this kind of teaching or engage in this kind of conversation?
It's a good question. I don't have a great answer for you. I mean, it's no different than 20 years ago, 25 years ago, it was all about communication. And so, again, we're still dealing with that. I mean, to some extent, the whole program that Orrin Levine put together was about communication. But it really started 25 years ago when there was a sense that we needed to do a better job of communicating. And they made all of these, the BEAR communication workshops, they made mandatory for staff. But like a lot of things, you could show up and not really engage and get the check marks to say you took the course. And again, not to sound biased, but the most people that were most likely to engage in the course were probably the people that had the fewest problems with communication to begin with. So again, it's exactly the same issue. It's just in a slightly different domain. Mm-hmm. So I don't have a great answer for you. People are who they are, and their level of personal insight may or may not change much given any courses that we make mandatory. So I don't know. Sometimes these changes in society are painfully slow. I think, I always feel good to think that it's the direction, not necessarily the speed. And sometimes you don't really have easy ways to influence the speed. Mm-hmm. Lots of things have changed from a societal perspective in the course of the last 25 or 30 years. Unfortunately, some things have gotten worse. Many things have gotten better.
And so when you think of it as, obviously, as learners, there's a lot of things that can be mandated to learners. When you think of it from the staff perspective, what are some barriers that anyone trying to implement programming or implement intervention is going to face when it comes trying to reach out to, say, mid-career staff?
Again, I don't know that there's too much from a barrier perspective with mid-career staff. I mean, I think the issue for most people is just essentially just time and energy. So again, it's about creating a space where people can focus just on the issues that are being discussed and that they have the mental energy to be able to engage. So, again, do you make that at 5 o'clock? Well, it's kind of hard to know that you make it at 5 o'clock, given my first example was people have to go home and make sure their kids get dinner. So you have to be prepared to create these spaces when it's convenient for everybody to attend. As you know, the world's been a little bit crazy over the last 2 years. And so, maybe when COVID's gone and maybe when EPIC's over, et cetera, but by even saying that, you're clearly prioritizing the challenges that are in front of you. Mm-hmm. And it's difficult not to prioritize some of those issues that are really necessary for simple operations. Mm-hmm. But maybe that's not the right way to think about it. Maybe the humanity of it all has to come first and the rest of it follows. But it's not easy to organize it that way.
No, absolutely not. It's just one fire at a time, isn't it?
Yeah.
Any last sentiments or statements before we wrap up?
No, I mean, again, I guess even the fact that you're having difficulties getting people to respond to the poll might be indicative of a problem. But it'd be interesting to even see how that piece gets written up, because there must be 60 or 80 faculty on your distribution list. If it takes you a long time to get 12 people, that sounds like a bit of a problem.
I think that there has certainly been and I am acknowledging this in my own reflection, a bias as to who is responding. And it's to that earlier piece that the ones who want to engage in the dialogue are always most likely to step forward to continue to have the conversation, as opposed to the voices that don't often have those conversations.
Yeah. Not a surprise.
No. But like you said, like those are the circumstances. You're not going to necessarily change that in the blink of an eye. In many ways, I find that, like you said, things change slowly and culture changes slowly. And sometimes some people just have to be taken for the ride. They're not going to be coming along of their own volition.
Yeah. No, that's called retirement.
I mean, it's a young department. I think many of them are a ways away off from retiring.
Well, we basically have a very bimodal peak at this point, right? So
yeah.
So absolutely. But no, I remain optimistic for the future. We just have another 5 years, and absolutely we'll have a very young department in 5 years.
Mm-hmm.
We're going to go very quickly to a position where it's going to be hard to actually find people. So.
Well, let me stop the recording at this juncture.